that the topic that we really want to kind of dwell, kind of dig deep into today is non-muscle invasive bladder cancer, but specifically surgical techniques. I think, there's a lot of interest and rightfully so in intravesical therapies, but I think, when you take one step before all of that, you got to get to diagnosis of bladder cancer, right? And especially in the non-muscle invasive setting, this is extremely important. And that really relies upon a transurethral bladder tumor resection, right? TURBT. And I think it's safe to say that we've been doing this probably the same way for about decades, right? I mean, we have a resectoscope, you have a bipolar monopolar loop, you take these tumors out in piecemeal, you send it for, you cauterize the base, and then you kind of send it off for pathologic analysis. But I think more recent, there is kind of an interest in maybe we stop doing these piecemeal resections for relatively smaller tumors and do something called an en-bloc TURBT. And I know that's something that you're personally interested in. You've done some work in this area, so I want to talk to you a little bit about this. So maybe just to kind of level set and to help everyone kind of understand, what is en-bloc TURBT and how is that kind of different than a conventional TURBT that we typically have been doing for many years?
Yeah, so I mean, bladder cancer is very strange in that it's one of the only diseases that will actually cut into the tumor before we remove it. Like you don't go and remove a kidney tumor by chopping it up into middle pieces and washing it out, or any other tumor for that matter. The idea is to cut into normal tissue, keep the tumor intact, and take it all out in one piece. And with the traditional TUR instruments, we actually just cut the tumor into small pieces and then wash out those small pieces. And as a result, there's a concern about seeding that cancer, little cells breaking off and reimplanting in other areas of the bladder. And perhaps that's contributing to the high rates of recurrence that we see in bladder cancer. And so that was the hypothesis. And, now we have more and more data that's showing that that is happening. But what the new technique is essentially, instead of cutting into the tumor, you cut around it. You kind of create a perimeter around it, and then you undermine the tumor and lift the whole thing up and take it all out in one piece. And that actually leads to numerous benefits, not just taking the tumor out in one piece, but also secondary benefits, which I'm happy to talk to you about.
Yeah. So essentially what you're saying is instead of piecemealing it, you're essentially kind of undermining it underneath, I guess, the lamina propria, maybe into some element of muscle. So talk to about like, how do you know, first off, what tools are you using here? Let's take one step back for that, right?
Sure.
Normally for a traditional TURBT, we're talking about resectoscope, bipolar, monopolar loop, whatever your preference is. And that's really all you really need, right? So what are the tools you need to successfully do an en-bloc TURBT?
I mean, you can do it with your existing equipment. Like you can use it with a bipolar resectoscope or monopolar resectoscope and just modify how you use the device to get the job done.
Okay.
But there's definitely like a learning curve, and there's techniques and ways of doing this. So the tools can be a monopolar loop. You can use a Collins knife, can actually be really useful because you can turn it sideways and kind of slice underneath the tumor. Or using a laser, like a holmium laser or thulium laser are both really effective. There are some advantages to the lasers. They tend to be a little bit more hemostatic, so you get less bleeding, and you don't get any obturator reflex. So if you're working on the sidewalls of the bladder, you can just laser away and you don't really have to worry about the obturator nerve being stimulated. So you tend to get substantially lower obturator reflexes. And since you can see very clearly the anatomic plane just below the lamina propria and just above the muscle, and kind of just cut the muscle fibers as they insert onto the lamina propria, you have actually lower risk of perforation as well with the en-bloc resection.
Okay, so essentially you can use the same techniques that we've always been doing with bipolar, monopolar, but you're saying that you could also use Collins knife as well as a laser when you do this. Are there specific types of tumors that you think are best suited for en-bloc TURBT versus maybe conventional TURBT? Let's go through some of those indications for you.
So, there's a limitation on how big of a tumor you can get out of the sheath. And so like on my Twitter page, for example, I posted a case some time ago of like the biggest tumor you could get out, which was about 4 centimeters. So anytime you get above 4 centimeters, it's just hard to get out. You have to cut the tumor in half to get it out. And then it's not clear if you're going to get the benefit that you thought you were going to have, at least in terms of the seeding risk. There are still other benefits, which we should talk about, but in terms of seeding risk, you may not solve that one. So yeah, you generally want to keep them under 4 centimeters. It's easiest when you're learning to do them on the trigone, because that's where if you make a perforation, it's not such a big deal. But the hardest places would probably be like dome, straight head on.
The dome. Right.
Because then you have to undermine behind the tumor, and kind of creating a hook to get behind and slice off the tumor is a little challenging. May not be the best case to start with.
So I just want to dig in just for a second about what you talked about. I think what you're saying is if something is too big for it to come out of the resectoscope, then you kind of have to cut it in half, right? So typically, 26, 28 French resectoscope. I mean, I tend to use a 26 French resectoscope. We're talking about tumors that are probably around 23 centimeters to 4 centimeters that can easily wash out of the scope. Is that kind of what I'm hearing as well?
Yeah, so a 3 centimeter tumor will come out pretty consistently. A 4 centimeter
Yeah.
tumor, you often have to put a basket or a bag in the resectoscope and take
Okay.
it out. So you'll often switch to like an offset nephroscope, like a 26 offset nephroscope, put that in. And then like in this opening where you normally would put your instruments, like a Perkins circle or something, you could stick a
Sure.
Perkins circle in, or like there's these bags they use in, I forgot the name of the bag, unfortunately, but when they do, um, what's the word I'm looking for? Like a sigmoidoscopy or
A colonoscopy.
colonoscopy.
Yeah.
They have a bag that actually is a pouch that goes in a small channel that you could use as well and encapsulate the whole thing and pull it out.
I see. I see. Okay. So sometimes you can and will have to kind of switch to an offset nephroscope if need be if the tumor is too big. Okay.
Yeah, if it's a
Understood.
really big one. If you're kind of pushing the limits once you get to 4 centimeters.